So I'll be presenting the case. It is about the lupus flare in a pregnant patient. My case, a 32-year-old female who is a known case of lupus nephritis, who was 32-week ANC, who presented with the complaints of elevated blood pressure, systolic blood pressure more than 170 millimeters of mercury, pedal edema, shortness of breath, which was around grade 1 to 2 at the time of presentation, and elevated serum creatinine level, which was 1.1 milligrams per deciliter at that time. Uh, I would like to go tell about the some past history. Patient is a known biopsy confirmed lupus nephritis class 4-5 and has hypertension for last 5 years. She had been on immunosuppression and antiproteinuric measures for the same. She has had received cyclophosphamide under lupus Eurolupus regime and was on oral prednisolone and was on mycophenolate mofetil and enalapril. She has had two relapses over the last 5 years. Patient conceived spontaneously while she was on treatment with the enalapril 1 year back, for which she required medical termination of pregnancy due to the risk of drug related teratogenicity. And after proper counseling and modification of drugs, she conceived spontaneously for the pregnancy. Prior to the current pregnancy, she required 10 milligrams of 10 milligrams per day of prednisolone and mycophenolate mofetil. Patient was switched from mycophenolate mofetil to azithromycin once pregnancy was planned. And with the diagnosis of pregnancy, her proteinuria started to worsen, and we had to upscale the prednisolone to 20 milligrams per day, which is the maximum recommended dose for the pregnancy. And in view of further worsening, she was started on tacrolimus, and over the duration of pregnancy, her proteinuria kept on worsening and her blood pressure became uncontrolled on single antihypertensive in 7 months. And regarding negative history, at the time of admission, she did not have any history of fever, cough, cold, headache, blurred vision, abdominal pain, vomiting, diarrhea, lower urinary tract symptoms, dysuria, hematuria, seizure, or loss of consciousness. On examination, she had grade 2 pitting edema and pulses were 94 per minute. Blood pressure was 160 by 100 millimeters of mercury on two antihypertensives, and respiratory rate was 20 per minute. Respiratory system examination was normal. SpO2 was 99% on room air. Per abdomen, no abnormality was detected and it was gravid. Fundus, no evidence of edema or retinopathy. Rest of the systemic examination was also within normal limits. And on presentation labs, hemoglobin was 10.54 gram per deciliter. WBC count was 12,000 per millimeters per cubic millimeters, and platelet count was 1,02,000. And her BUN was 19 milligrams per deciliter. Serum creatinine was 1.1 milligrams per deciliter. Urine examination showed protein was 3 plus. 15 to 20 pus were present, and 24-hour urine protein was 5,700 milligrams per day, for which we further managed her by we referred her the patient to the obstetric departments, and final diagnosis of preeclampsia was made, and she was advised for observation until 34 weeks of gestation by the obs. But her antihypertensive requirement kept on increasing from 2 to 3 in the maximum doses, and also her serum creatinine rose from 1.1 to 2.1, and also worsening of symptoms happened along with the O2 requirement was O2 oxygen was required for the patient, and patient required to be shifted to MICU in view of worsening symptoms, and diagnosis of severe preeclampsia was made, and patient was taken for lower section, cesarean section, and baby was delivered, which was 1200 grams, which required NICU admission on and also required O2. Later, baby was discharged after 24 days. After the LSCS, patient's condition improved, her BP controlled, and only single antihypertensive requirement continued. And edema also resolved. Renal function tests were normalized. Patient was discharged after 5 days of LSCS on one antihypertensive, and at present also we are following her, and she is in partial remission on MMF steroids and uh, MMF and steroids. Yes. My provisional diagnosis for the case were lupus nephritis and flare versus the acute severe preeclampsia along with acute kidney injury. My final impression for the case was systemic lupus erythematosus with lupus nephritis class 4 5, hypertension with preeclampsia with 7-month pregnancy status post LCS, preterm delivery. So should I go ahead with the discussion?
Yes, yes, quick.
Yes, sir. So, diagnostic criteria for preeclampsia. Preeclampsia is defined by systolic blood pressure of more than 140 millimeters of mercury, systolic, and diastolic for more than 90 millimeters of mercury on at least two occasions, at least 4 hours apart, after 20 weeks of gestation in previously normotensive patients, and at least one of the following symptoms to be there. That is proteinuria more than 0.3 gram in 24-hour urine specimen, or UPCR ratio of more than 0.3 in a random urine sample, or by dipstick it could be +2 or more. Platelet count should be less than 1 lakh. Serum creatinine should be more than 1.1 milligrams per deciliter, or doubling of the creatinine concentration. In the absence of any other kidney disease, rise of the liver transaminase at least twice the upper limit. Pulmonary edema, new onset and persistent headache not accounted by alternative diagnosis, and not responding to usual dose of analgesic. Visual symptoms like blurred vision, flashing lights or sparks, scotomata. Active we need The main differentials were active lupus nephritis versus preeclampsia, which can be differentiated by symptoms. Active lupus nephritis would present any time during the pregnancy, but preeclampsia presents only more than 20 weeks of pregnancy. Hypertension can be present in both, and extrarenal systemic lupus signs will be present in active lupus nephritis but not in preeclampsia. Serum uric acid level is an important marker which would be elevated in preeclampsia but not in the active lupus nephritis. Complement level would be decreased in active lupus nephritis while it will be normal in preeclampsia. Anti-dsDNA level would increase in active lupus nephritis. Active urinary sediments would be seen in active lupus nephritis only, and urinary calcium excretion would be increased in active lupus nephritis but not in preeclampsia. And SFLT1 ratio versus SFLT1 versus PIGF ratio is an important marker which is not readily available, but it is elevated during the preeclampsia, and it is a marker of severe preeclampsia. And proteinuria would be more elevated. Proteinuria can be seen in both preeclampsia and active lupus nephritis. 24-hour urinary calcium would be elevated in active lupus nephritis, and complement level drop can be seen in active lupus nephritis. And recommendations about how to go ahead with the lupus in the pregnancy. During preconception, we need to see that the disease is stable and in remission for at least 6 months, and all the medicines which are advised has to be changed accordingly. And we need to perform the thorough evaluation for the disease activity and organ involvement, and ensure that lupus nephritis is in remission or low activity. And while during the pregnancy, we need to advise on the likelihood of preterm delivery and increase the risk of operative delivery, and monitor the lupus nephritis activity closely, and conduct the fetal scans including the fetal echocardiography, which is also necessary in case if there is positivity for anti-Ro or antibodies. And we need to differentiate between the lupus nephritis flare versus the preeclampsia, and also be vigilant for preeclampsia development after 20 weeks gestation. And we need to tailor the requirements of monitoring as well as drug therapy. And while in postpartum period, monitor for the lupus nephritis flare and thromboembolic event is needed for the 6 months postpartum, and encourage the breastfeeding also, and follow up closely for postpartum any issues if developed. And further discussion, active lupus nephritis is strongly associated with the poor maternal outcome. Pre-pregnancy evaluation is essential for all the patients. Active lupus nephritis is associated with the poor pregnancy outcome to both mother and the baby, and they include maternal lupus flare, gestation hypertension, preeclampsia, as well as prematurity of the newborn. Intrauterine growth retardation and spontaneous miscarriage can also happen. And I would like to discuss this that about the lupus nephritis, how to go ahead with the treatment protocol. First of all, there should be evaluation which should include the shared decision making with the patient and the doctor, and we need to stratify each patient individually. And certain biochemistries are important, like biochemistries, urine analysis, and urine protein quantification, anti-dsDNA levels, complement level, APLA profile. and risks are to be measured before going ahead with the pregnancy. That is, if there is chance of, and also need to communicate with the patient too. That is, there is chance of lupus flare associated with the pregnancy, and higher incidence of thromboembolic events, sepsis, and hematological complications, and also preeclampsia and death. Uh, and also, we need to discuss about the miscarriages, preterm delivery, IUGR, SGA, stillbirth, neonatal lupus, and death. And regarding the fertility in the lupus patients, GnRH and GnRH agonists are advised to preserve the fertility, and contraceptions are also required to be told to the patient and given all the choices whatsoever is preferred by the patient as per the her choice. There are certain drugs which can be discussed, which are to be given in lupus nephritis. Their toxicity and contraindication or caution or safer drugs during the pregnancy as well as the breastfeeding. During the pregnancy time, hydroxychloroquine, corticosteroids, azathioprine, and cyclosporin are safe. At the same time, ACE inhibitors, cyclophosphamide, mycophenolate mofetil, SGLT2 inhibitors, methotrexate, leflunomide, voclosporin, they are to be contraindicated. That is, they are to be avoided. While if you are using NSAIDs, tacrolimus, Ritux, belimumab, or anifrolumab, they are to be used very cautiously, and much of the data is not really available about it, but we are using tacrolimus. And in lactation, during the lactation period, we can use with the go ahead with the corticosteroids, azathioprine, cyclosporin, hydroxychloroquine, tacrolimus, Ritux, and NSAIDs. But methotrexate, leflunomide, cyclophosphamide, and SGLT2 inhibitors are to be avoided. Along with the limited data is available for ACE inhibitor, belimumab, mycophenolate mofetil, voclosporin, and anifrolumab.